Good morning and good afternoon. I'm Selena Shonkin, Executive Director of TogetHER Health and the moderator for this webinar. Welcome to our webinar, Saving Lives with Integration, HIV and Cervical Cancer Prevention Integration. This webinar is sponsored by TogetHER Health with our partners FHI 360 and PATH. We're very grateful that you've taken time to join us today at a time of much global disruption. I'm sure many of you are participating in this webinar from home. I hope that you and your loved ones are safe and comfortable during this time. And we're so glad that you're taking the time to focus on a very important topic that kills tens or hundreds of thousands of women every year, the increased risk of cervical cancer among HIV-positive women. We have a very accomplished panel today, and I will introduce each of them in turn. A few housekeeping notes before we begin. Everyone's phone is muted. We will welcome questions and we'll try to answer as many as possible after each of the speakers and at the end of the webinar. Please write your questions in the Q&A box on your screen. We'll post the video with the presentations on our website, togetherforhealth.org, within a couple of days. And now I'd like to introduce our first speaker, Dr. Chemtai Mungu. She was born and raised in Kenya and is an obstetrician gynecologist and global health fellow at the University of California, San Francisco. She received a bachelor's degree with honors from the University of California in Berkeley and completed medical training at UCSF. She also holds a master's degree in public health from the Johns Hopkins School of Public Health. As a medical student, she was awarded a Doris Duke International Clinical Research Fellowship and spent a year in Kisumu, Kenya, working on cervical cancer prevention among HIV-infected women. Dr. Mungu is passionate about using clinical research, advocacy, and public health to advance women's health in sub-Saharan Africa. As a fellow at the University of California, San Francisco, she's the principal investigator of several studies at PEPFAR-funded clinics in Kisumu, implementing evidence-based cervical cancer prevention among HIV-infected women, including the use of HIV self-sampling, alternative ablative treatment methods for precancer, and the use of automated algorithms for cervical cancer screening among HIV-positive women. Her work is supported by the National Institutes of Health, the National Cancer Institute, and the UCSF Global Cancer Program. Dr. Mungu?
All right, thank you so much for having me, and thank you everybody for signing up for this important webinar and topic. So I'll be talking about the science of the intersecting epidemics of HIV and cervical cancer. For the outline of my presentation, I'll take the next slide. We'll talk about the epidemiology of cervical cancer. We'll discuss in a little bit of detail the science of why cervical cancer is different in the context of HIV infection. And lastly, we'll talk a little bit about the funding landscape for integrating both of these services. Next slide. So cervical cancer is a disease of great health inequity. By this, I mean that where you live determines whether or not you will get this disease, and unfortunately, whether you will die from it. It's one of the cancers that are most common amongst women in developing countries. So approximately 600,000 women every year are diagnosed with cervical cancer, and about 85% of these women live in low-resource settings. So this map here shows you that the darker colored countries, which are the countries in sub-Saharan Africa, Southeast Asia, and South America, contributes the most burden of cervical cancer. And 9 out of 10 women who die from cervical cancer, again, come from these countries. And this is a reflection of the fact that it is a preventable cancer, and countries with access to screening have really been able to prevent their communities from dying from cervical cancer. We'll take the next slide. And this is another slide again, just to show you the significant disparity of who dies from cervical cancer. The countries, you see that United States, North America, only 2.4 women per 100,000 women die from cervical cancer every year, compared to Malawi, where almost 80 women per 100,000 women are dying from cervical cancer. Again, a great disparity because of access to tools that we already have that science gives us for prevention. I'll take the next slide. So talking about HIV and cervical cancer, these are epidemics of inequality, and they're intersecting epidemics. This is a map of the HIV prevalence around the world. And unfortunately, as you see, the same countries that suffer a disproportionate burden of cervical cancer are the same countries that have the highest HIV prevalence, with many countries in sub-Saharan Africa having more than 10% or 5 to 10% HIV prevalence. So out of about 37 million people around the world who have HIV, 90% of them live in these low resource settings. 52% are women. And these two epidemics really reflect health, gender, socioeconomic, and health inequities that track along the lines of poverty and lack of agency for women who live in these settings. I'll take the next slide. So the etiology of cervical cancer, or the pathogenesis, has been described. This is one of the cancers that we know what causes it. And this is why countries have successfully been able to significantly reduce the burden. We know that infection with human papillomavirus, HPV, once persistent in the cervix, will cause precancerous changes that over time progress to cervical cancer. So we have two time points of prevention: primary prevention with HPV vaccination that is now being rolled out throughout the world and even in low resource settings, and secondary prevention. And this is where, during a woman's lifetime, when she's been exposed to HPV, where you have 10, 15 years where those precancerous changes take time to become cancer, that is the time that secondary prevention through regular screening, really you can eliminate this disease. And this is why countries in North America and other places have such little incidence. It's because they have regular access to screening, even before they got the HPV vaccine. I'll take the next slide. So how is cervical cancer different in the context of HIV infection? Science tells us that compared to an HIV-negative woman, a woman who has HIV is more likely to acquire HPV infection. Once she has HPV infection, she's unlikely to clear it, so it tends to stick around longer because of her weakened immune system. And the period from the HPV infection to persistence and progression to precancer is much shorter. So as an HIV positive woman might have 10, 15 years, in HIV, as an HIV negative woman might have 10 to 15 years of progression time to precancer. This time is much shorter in HIV positive women. Same when an HIV positive woman is treated for precancer, her risk of recurrence is much higher compared to an HIV negative woman. And finally, HIV positive women get invasive cancer much quicker and at much younger diagnosis. And this is something that healthcare workers in low resource settings will testify to. They see women in their 25, 30, 35 who are HIV positive who get cervical cancer. So this really is why this is a really critical cancer to prevent in this community of women. I'll take the next slide. So the world has made significant gains against the fight against HIV/AIDS. I think this graph shows initially in the 90s where the deaths from HIV was very high. We all remember this time where there was significant stigma. It's called slim disease, very associated with mortality. Almost everybody who got it died from it. But over the years, through scientific advances, HIV is really a chronic disease now in much of the world. And with universal access to treatment, with a focus on viral suppression, and even with the talks of elimination of HIV prevention. So really we have a group of 18.8 million women who have been kept alive by antiretroviral drugs who now are at significant risk of dying from cervical cancer if we don't offer prevention efforts. I'll take the next slide. So several things that HIV programs really focused on. that we might falsely think is protective against cervical cancer. So one question, is being on antiretroviral therapy protective for HIV positive women, especially in the context of treat everybody, focus on viral suppression? This study looked at this question, whether the incidence of cervical cancer changed the longer a woman was on antiretroviral therapy. So looking over a 5-year period, we compared this, these authors compared South Africa, Latin America, North America, and Europe. And they found that particularly in North America and Europe, the incidence of cervical cancer decreased quite a bit as every year the woman was on antiretroviral therapy. But looking at the graph for South Africa, it's very evident that the cases of cervical cancer did not change, even if a woman is on antiretroviral therapy for 5 years. And this really is reflecting the fact that without screening, even if there is good adherence to ARBs, women still get cervical cancer. I'll take the next slide. Next is this question of, are high CD4 counts, again, protective against cervical cancer? Again, this is a huge focus of efforts for HIV programs on focusing on viral suppression, adherence, high CD4 counts. While this is not a clear question and there's some confounding factors, we see in the study from 2007 that compared to other cancers such as Kaposi sarcoma, which is also an AIDS-related cancer, which is at the corner there, the higher the CD4 counts, in general, the incidence of Kaposi sarcoma went down. But looking at graph C, which is right at the upper quadrant, with cervical cancer, that relationship is not so clear. So just because a woman has high CD4 count doesn't mean that she will not get cervical cancer. I'll take the next slide. And finally, what is survival following a diagnosis of cervical cancer for HIV positive women? So this is a rather grim statistic or slide. And these are data from Uganda and Botswana, and really reflects the reality for most countries, low-income countries. In both of these studies, they looked at what happens to a woman who is HIV positive, who's on ARTs, who gets diagnosed with cervical cancer. 2 years later, how is she doing? What's happening to her? These are Kaplan-Meier curves, which are for those who are epidemiologically inclined. But basically, we're looking at this great slope that, starting from month 0 to month 24, where only 25% of women, so looking at the Uganda curve, the blue line is HIV positive women. So at 24 months, only 25% of women are still alive who are HIV positive following a diagnosis of cervical cancer. So literally in 2 years, only 1 out of 4 women will be alive once they get a diagnosis in these 2 countries. Same thing in Botswana. So very distressing, because even in the presence of ARVs and viral suppression, really once a woman is diagnosed with cervical cancer, their risk of death is very high. I'll take the next slide. So for those working in HIV care, really this is a moral imperative to offer screening for women who are HIV positive. And to quote the former president, it makes no sense to save a woman's life from HIV and AIDS, only to let her die from a preventable and treatable cervical cancer. Again, we have the tools for prevention. It's just a matter of rolling them out in these communities. And programs must really emphasize on the cascade, similar to making sure that there's virologic suppression, there's adherence. Every woman who's getting HIV care should get screening, and then those who are eligible should get treatment, and those who are treated should have adequate follow-up, because we know recurrence is high. So really that very strict focus on the cascade and not just screening is what will get us benefit. I'll take the next slide. So a lot of work is put into funding for HIV care primarily, and we have seen those gains that are set to be lost with cervical cancer. So what is the funding landscape? Our organization is appreciating that you can't offer HIV care by itself. I'll quickly emphasize two organizations or several organizations that are now offering funding to integrate both cervical cancer work and HIV work. Global Fund, current cycle is providing funding that will offer training of doctors and nurses, integrate both services, doing integration in ART clinics, in family planning clinics, in maternal child health clinics. PEPFAR is now rolling out cervical cancer integration into its eligible countries. So these slides will be available. If you work in a program, please follow it up and look at eligibility. And for example, PEPFAR is also able to help pay for procurement of supplies, which we know is a big problem on the ground. I'll take the final slide. Unitaid is another organization that's currently working to fund integration of cervical cancer and HIV. And working with the Clinton Initiative, their focus is on getting low-cost screening tools on the ground, including HPV testing. So this is something to look into as well as several other organizations. And really, there's funding from research organizations, national governments now following the WHO call of cervical cancer elimination, are putting a focus on cervical cancer screening. So there's multiple avenues for programs to put together money and to be able to offer this critical service that HIV positive women must have if we are really to get the gains of being on ARTs. I'll take my final slide. So thank you so much for giving me this opportunity, and I'll take any questions.
Thank you so much, Dr. Mungu, for an excellent presentation. It's excellent. I wanted to ask one quick clarifying question before we move on, and that comes from Dr. Tonui in Eldoret, Kenya. He says, or she says, I'm not sure, the risk of dying in 2 years for HIV-positive diagnosed women with cervical cancer is unbelievably high. Is this for treated or untreated women?
Thank you. That is a great question. These data are for women who have tried to access treatment. And I think the problem is that access to treatment is very weak, and access to radiation therapy particularly, which is the mainstay of treatment, is not strong in most of these countries. So even with attempts at accessing treatment, because of the significant gaps in travel costs, in time to leave work, that women cannot be able to make the sacrifice, a lot of women are not able to access it. So this is more real life data and reflects the facts that there's other factors that prevent women from actually getting the treatment.
Excellent, thank you. I'd like to move on to our next presentation now, which is Dr. Emeka Franklin Okechukwu, who is a senior public health specialist with more than 15 years of experience in public health program planning, designing, implementation, monitoring, and leadership. Dr. Okechukwu currently serves as FHI 360 Technical Director and Deputy Chief of Party for the USAID Boresha Afya Southern Zone Project in Tanzania. In this role, he provides strategic technical leadership to the implementation of PEPFAR-funded integrated health service delivery and comprehensive HIV care and treatment services, TB, malaria, family planning, and maternal and child health in 6 regions in southern Tanzania. Previously, he worked as treatment program manager with USAID Nigeria and as senior medical services advisor at FHI 360 Nigeria. Please go ahead.
Thank you so much, and welcome everyone on this part. I will be speaking on the implementation of cervical cancer program integration. So we'll be looking at how this project, USAID Boresha Afya Southern Zone, implement this integration. Next slide. Yeah, just to provide a brief overview of the project. This project is an integrated project that covers HIV, tuberculosis, malaria, family planning, and maternal and child health. Is actually funded by USAID Tanzania to implement in 43 districts in 6 southern regions of Tanzania. It's implemented by 4 partners, Deloitte in Gender Health Management and Development for Health, and FHI 360. FHI 360 is the technical lead in this consortium. Next slide. Yeah, let me just briefly discuss the Tanzanian context in line with the guideline for Tanzania implementation of cervical cancer service delivery. It's divided into 3 broad areas: primary prevention, secondary prevention, and tertiary care for cervical cancer. Of course, primary prevention is essentially health education and SBCC interventions and HPV vaccination. And of course, tertiary care is now real treatment for cervical cancer. But for the interest of this webinar, we'll be discussing more on secondary prevention. And that, simply put, is early identification and treatment of precancerous stage. Then, of course, appropriate referral for treatment. Next slide. So talking about secondary prevention, it's essentially screening to identify at the early precancerous stage those who have this stage of cancer, which is treatable. And that's using visual inspection with acetic acid. I will be using the acronym VIA more often. While this VIA approach is very, very useful programmatically because it provides immediate results and makes it feasible for identification to be directly linked with treatment. So in Tanzania here and in the project, we use single visit approach, which means once screening is done and a woman tests or screen positive VIA will immediately be offered treatment. And this reduces attrition and is also cost effective. It doesn't require a lot of training. It doesn't require a lot of expertise. It doesn't require super specialists to implement this or to do this. Just using simple equipment, and you have the nurses who are trained to do that. But anyway, it depends on the visibility of squamocommular junction of the cervix. That is, again, the technique of the person viewing it will be also very important. Of course, women with 3 consecutive negative VI results will need to discontinue after age of 60. Next slide. So for Tanzania National Guideline and the context in there, it generally broadly divides it into 2 categories: women who are HIV positive and those who are HIV negative. So the frequency of screening, essentially, the guideline states that it should be at HIV diagnosis, no matter the age, and also there should be annual screening, regardless of result, until 3 consecutive negative results. But for HIV negative women, then it's between the age of 30 to 50 years. But again, this can be expanded to cover age of 25 to 59. And for VIA negative women, the rescreening should be every 3 years. But for positive, the repeat screening should be in 1 year. Repeat screening after treatment should be after a year. Then if the follow-up result is negative, then they will be reverted to 3-year screening. Next slide. And for the project being funded by PEPFAR, we also have PEPFAR guidance, and which we try to follow, marrying that with the Tanzanian guidance. So PEPFAR guidance is actually focused on HIV positive women. As we know, PEPFAR fund is the target population for PEPFAR program is HIV positive individuals. So the guidance is actually for the age between 15 to 49. And for those who are VIA negative, the repeat screening should be every 2 years, while those who are VIA positive should have the repeat screening after a year post-treatment. Next slide. So I'm going ahead now to itemize some of the issues regarding implementation or operationalization of this program to integrate cervical cancer service delivery, which is essentially screening and treatment and referral to HIV program. So what we did first was to engage the relevant government of Tanzania stakeholders and to get their buy-in, especially the lower levels health authorities, that's called the regional and council health management teams, whose job is to supervise the health facilities that the project is supporting. Once we get their buy-in and get them on the same page, we conducted a baseline assessment. We realized there have been some piecemeal services by previous projects, and there have been also some few equipments and trainings done by previous projects. So the baseline assessment revealed all those things. So we're able to note the available trained staff, when were they trained, type of training, where they are posted, and also to determine the available materials and equipment and even their functionality, and also the spaces for the service delivery points. All these we gathered and we were able to develop an activation plan, and immediately we rolled out this program. Of course, HIV program started first, so this is just an add-on to that. We conducted a joint review of the service delivery points because this warranted a lot of creating new service delivery points, shifting things, moving things around, even revising the patient flow so that patients, when they come for their ARV refills, they will not shunt the service delivery point for cervical cancer screening. So we had to move around the patient flow and several other service delivery points to accommodate this. Then we did an orientation for the providers and educated them on the documentation required and familiarized them with the tools. Next slide. Then the next thing the project did was to make sure that the facilities have commodities and supplies. The cryotherapy machine that is in good order, if the needs repair is fixed, and the project also procured some cryotherapy machine. Of course, the cylinders for the gas, in this case we use carbon dioxide, specular, light source, waste bins, then other supplies. And these are some of the pictures from the site. The bamboo stick, the vinegar that has the acetic acid, the cotton swabs, the gauze, and other personal protective equipment. Next slide. So this is just a picture to show one of the setup in one of the facilities being supported, showing some of the items I mentioned earlier. Next. And this is another picture showing a typical service delivery point in one of the facilities that we set up in the HIV care and treatment center that we support. I think you can see some of those equipments I mentioned, and setting up this space requires a lot of negotiation with the facility management team. Next slide. Yes, so this is also training, which is another input from the project. A lot of people, we found out that some were trained before that, and we had these facilities who had previously implemented it. So we reactivated them and added additional facilities, added more people trained, and expanded the service delivery points. Some of them were located in the outpatient department, some in the reproductive and child health area, the antenatal area, but we have to move things around and bring some of the service delivery points in the HIV care and treatment service delivery point so that the proximity to that service will reduce the attrition rate. Next. Yeah, other things we are doing right now is to continue supportive supervision, clinical mentorship, and other on-the-job training. We've included cervical cancer screening on our quality improvement program, looking at the cascade, and also making sure that the equipments are required are maintained, that the supplies and consumables are not out of stock, and the MIE monitoring evaluation support is provided, making sure that all the data are well documented and reviewed and used for decision making, and of course the commodity consumption forecasting and supply. So all these that we continue to do to ensure there is no service interruption. Next slide. Yeah, I want to show some of the results we've seen. The last quarter, which is from October to December 2019, which we call quarter one by PEPFAR definition, we had 10,850 women screened, and this resulted in 5% screened VIA positive. And out of that 5% positive, we had 98% treatment coverage. That means 98% of those who are eligible for either cryotherapy or LEAP or even a referral for other services were given. So the positivity rate for screening is 5% for that quarter. Next slide. This is the cascade that PEPFAR actually wants, and that's how we report it. For the facilities we are supporting, we have 61,000 women who are eligible for screening within the age of 15 to 49 that are HIV positive and are currently on HIV treatment. And cumulatively, we have screened 51% of them, and 5% of them were VIA positive, and 90% got one form of appropriate treatment. And this is in line with the PEPFAR guidance. The expectation is that out of those who are eligible, there will be 50% screening rate, considering that the frequency is once in 2 years. So the program is expected to screen 50% every year. Then the positivity rate should lie between 5 to 28, and treatment rate should be around 90. This is PEPFAR expectation, and the project is in line with that expectation. Next. Yeah, this table tried to just disaggregate that cumulative result I explained earlier into the previous quarters, and it just showed cumulatively how we are ramping up the screening and the results we are getting. But on average, I think there's still a lot to be done to improve the screening and also the treatment coverage. The cancer rates is PEPFAR expects 1 to 2%, but we are getting higher rates. Next. Yes, having reviewed our data, we're able to look at what can we do differently in this year. And for us to increase the screening rate, we have to do something different. And what we decided to do is to do an outreach services, and that means taking the services beyond those facilities that are few, that have those cervical cancer screening capability. So we mapped out facilities and made them into hubs and spokes based on proximity and patient load. Then we are really rolling out outreach services to these peripheral facilities. Then we are tracking closely the cascades to ensure that there is no missed opportunities. Then we also consider using SMS reminder to improve service uptake. We started in quarter one, and we've seen, you can see the dark part of the bar, those who are actually screened through outreach. And we expect this dark part of the bar to increase with time. Next slide. Yeah, so I think this is the last slide, and it's showing some of the challenges. The coverage is still poor because out of 618 facilities supported by HIV services, we have only 84 with cryotherapy. And we have the service delivery points in some areas, making it difficult for linkages. So as a recommendation, we want to embark on outreaches and decentralize the service delivery points and ensure active referral, probably escort services for those who screen VIA positive to make sure they get treated. Another challenge is weak documentation. Cervical cancer services are not integrated into HIV database, and so it's difficult to have a more longitudinal patient follow-up and no unique ID for cervical cancer. So we are doing manual data collection, and we continue to engage Ministry of Health to ensure that the data for cervical cancer is well integrated. Then, of course, the human resources for health is inadequate. The number of trained facility providers, and the program has a plan to improve on that. And of course, the referral system is weak, and we can't really see how many of those with suspected cancer diagnosis that really got the cancer treatment when they are referred out. So these are the basic challenges and recommendations that the project is implementing. Next, I think that's the last. Thank you so much for listening.
Thank you so much, Dr. Okechukwu. This was a fantastic presentation. And as you will see, there are many questions that people have asked you. In the interest of time, I'm going to ask you to review those questions, and we'll address them later after Dr. Carrie Thompson's presentation. Dr. Thompson is a research officer in the Sexual and Reproductive Health Program at PATH, a global health nonprofit focused on advancing health equity through innovation and partnerships. Since discovering her passion for public health during her undergraduate studies in Kenya, she has spent 20 years working across local, state, and federal levels of the US public health system and for international non-governmental organizations. Her prior roles have included working on refugee health with the Centers for Disease Control Division of Reproductive Health, evaluating cervical cancer screening in Guatemala for the American Cancer Society, and prevention of mother-to-child transmission of HIV with Médecins Sans Frontières in Kenya. Dr. Thompson received a PhD in epidemiology from the University of Washington and an MPH in global health from Emory University. Dr. Thompson's current portfolio at PATH focuses on improving access to and quality of cervical cancer screening and treatment in low and middle income countries. Dr. Thompson? Dr. Thompson, we can't hear you. Can you please unmute your phone? We can see your slides, but we cannot hear you. Dr. Thompson?
Can you hear me now?
Yes, we can.
Okay. Sorry about that. Petra, I do think you will need to drive because I do not see the controls. Thank you. So greetings to everyone. Sorry for the momentary technical difficulties. I want to first thank TogetHER for all their efforts to elevate cervical cancer as a global public health issue, and specifically for convening this webinar on such an important topic. With my presentation, I'll be switching the focus to a different geographic region where the dual burden of cervical cancer and HIV is also high, and I'll be sharing with you the rationale and concept for a new clinical trial we have planned in the Dominican Republic. To start us off, just for context, I'll say a few words on past institutional history working in the areas of HIV and cervical cancer, and specifically briefly highlight some of our work we've been doing in the Latin American region. Next, I'll be introducing a new NIH-funded collaborative agreement for responding to the dual burden of cervical cancer and HIV in this region, and summarize some of the unanswered questions that I currently see our field grappling with. Later this year, we will be launching Estudio Oportunidad in the Dominican Republic, And while our protocol is still very much in development, I'm happy today to be able to share our overall study aim, our initial plans for the study design, and some possible opportunities to answer additional research questions. Next slide, please. Oh, am I? So PATH has been working in HIV for over 3 decades and across multiple geographies in the areas of prevention, testing, and treatment. Most relevant to our topic today, and similar to the service delivery activities we just heard about from FHI 360, PATH has been supporting women of reproductive age to initiate ART and remain in the HIV care cascade, which, as we're talking about today, is a critical window of opportunity for integrated services. Next slide, please. In parallel, PATH has been addressing cervical cancer prevention across the life course and prevention continuum in low resource settings. We've been advancing primary prevention through national introduction of HPV vaccine and accelerating the adoption of strategies and technologies such as HPV testing and thermal ablation that we see as having the potential to improve the coverage and quality of national screening programs. Next slide, please. In our scale-up project, PATH has been partnering with ministries of health to introduce HPV testing in the Central American region. This has included training providers and lab technicians, modifying guidelines and clinic systems, and importantly, expanding the screening options for women to be able to forego pelvic exams in favor of collecting their own samples, what we call self-sampling for HPV testing. Next slide, please. So as we've seen in some of the previous work presented today, the introduction of a screening program can be accompanied by many different clinic visits and some potential bottlenecks, which is one reason why the single visit approach that we saw a few moments ago has so many benefits. When we think about potentially transitioning to HPV testing, this brings along its own benefits, but it can be complicated with, as I said, these multiple steps and clinic visits, as this graphic that was designed by 2 of my colleagues at PATH shows. I want to echo something that Chemtai said as she ended her presentation, which is that screening is only effective when screen-positive women successfully complete treatment. So efforts to streamline screening and retain women throughout this screening and treatment cascade are essential, and we need to keep that in mind moving forward. Next slide, please. So we are very pleased to have the opportunity to combine PATH's experience across these 3 different domains into a new project that is focused on cervical cancer prevention among women living with HIV in the Dominican Republic. We heard earlier some of the stark research statistics and epidemiology that women living with HIV have a higher incidence of cervical cancer and are also more likely to have a high reoccurrence of lesions even after treatment as compared to their HIV uninfected female peers. We know that this dual burden is most significant in sub-Saharan Africa, but it is also a concern in Latin America and the Caribbean, which is home to the 2nd highest HIV prevalence. So in the study that I'll be introducing in a few moments, we are specifically focused on the Dominican Republic. This is a place where cervical cancer incidence is also high relative to some of the North American and European countries that Chemtai showed on her slide earlier. And it's also the leading cause of death among women of reproductive age. And in this setting, in the Dominican Republic, the current standard of care for screening is PAP or VIA. Next slide, please. So Chemtai also gave us a nice summary of some of the current funding opportunities available to advance cervical cancer and HIV prevention, cervical cancer prevention among HIV infected women. And here I want to highlight another mechanism, which is more of a research mechanism. And so in response to the dual burden of cervical cancer and HIV, and specifically the disproportionate burden in the Latin American region, the National Institutes of Health have funded a new clinical trial network called ULACnet, which is specifically focused on addressing some of these pending research questions around HPV-related cancers among people living with HIV. ULACnet consists of 3 partnerships which span 5 Latin American and Caribbean countries, and it specifically has a focus on capacity building for clinical research. Each of the 3 partnerships are, next slide please, each of the 3 partnerships are implementing 3 clinical trials that each address HPV vaccination for primary prevention, that each address a different aspect of this question. So all of the partnership centers are addressing HPV vaccination for primary prevention, cancer screening, and lastly, options for non-surgical treatment. Next slide, please. So PATH is going to be part of Colaboración Evita, which includes 3 different clinical trials addressing these different strategies for preventing HPV-related cancers that I just highlighted. And we are most specifically involved in Estudio Oportunidad, which is a collaboration with the Fred Hutch Cancer Research Center and our local country partners. And this study that I'll be discussing in a few moments is most specifically focused on cervical cancer screening and taking place in the Dominican Republic. Next slide, please. As highlighted by the previous presentations, there's a compelling need and opportunities to integrate routine cervical cancer screening into existing HIV service delivery. But as we all know, this is accompanied by challenges and some pending questions for implementation. For example, the WHO draft strategy for cervical cancer elimination is currently proposing twice in a lifetime screening using what they call high precision tests. For the general population, relying on more accurate screening can allow us to relax screening frequency, but based on what we know about the risks, more frequent screening is needed among women living with HIV. At the same time, options for cervical cancer screening are rapidly expanding. 2 of the most recent changes are the increased availability of HPV assays and the application of machine learning and artificial intelligence to cervical imaging. However, existing research suggests that screening approaches have differential performance among HIV-infected women, and I'll give a few examples of this in my next slide. This could potentially point toward the need for a second test, sometimes referred to as a triage test, and it's currently not clear which test or combination test is most accurate for cervical cancer screening among women living with HIV. We always have to remember the realities of service delivery, and from this perspective, it is true that women living with HIV have more frequent touch points with the HIV care system as part of receiving HIV care and ART management. But at the same time, we need to be judicious about the use of resources and not be going in a direction of overscreening or overtreating these women. Next slide, please. I want to expand briefly on my earlier point about differential test performance among women living with HIV. As described earlier, VIA is a low-cost screening method that can be deployed at most primary care centers. It can facilitate this single-visit approach, and so it offers tremendous operational advantages. However, some research to date suggests that the sensitivity of VIA is markedly lower among women living with HIV. And when a screening test has reduced sensitivity, what we're worried about are the consequences of missing a case and thinking about when is the next opportunity she might be screened and have her cervical precancer or cancer detected. Conversely, HPV testing, two of the examples shown here are hybrid capture and CARE-HPV, have been shown to have reduced specificity among women living with HIV, which can lead to incorrect diagnosis, referral, and potential overtreatment. Next slide, please. So, putting this all together, cervical cancer screening and triage among women living with HIV does need some refinement to optimize detection, reduce overtreatment, and facilitate implementation in low and middle income countries that are most affected by this dual burden. The aim of Estudio Oportunidad is to develop an efficient algorithm for cervical cancer screening among women living with HIV. And we also aim to look for differences in screening performance by characteristics such as age, viral load, and time on ART. Next slide, please. As I mentioned earlier, our protocol is still very much in development and is subject to change. As of now, our aim is to enroll 600 women living with HIV in the Santo Domingo area in a longitudinal study. Women who are enrolled and are receiving HIV care at public sector clinics will be assessed for initial eligibility and referred to the IDCP study site. Women who meet eligibility criteria that is listed here on the slide will be enrolled and complete all study visits at IDCP, which is a well-established clinical research site for longitudinal HIV trials. Next slide, please. This is a draft, shown here on this slide is a draft of our study flow. We will be documenting HIV viral load at baseline, and then all women who are enrolled will receive all of the screening tests included. The frequency of follow-up study visits will vary depending on a woman's initial screening results. Here it shows that women who are negative on all screening tests will only be followed up and rescreened after 2 years, although we're hoping to increase the frequency of rescreening to more closely monitor changes in this at-risk group. Women with SIN2+ may be eligible for a different trial specific to novel treatment approaches, but otherwise, for our parent protocol, we plan to treat cervical precancer with thermal ablation. Next slide, please. The screening tests that are current candidates and under consideration for inclusion are PAP and VIA to represent their current standard of care in the Dominican Republic, automated visual evaluation, HPV testing with genotyping, testing for oncoproteins E6, E7, and also methylation. And women with visible lesions detected will also have biopsies. Next slide, please. So because the protocol is still at an early stage, we do have some possibilities to embed additional questions or ancillary studies. And I've listed some of them here that my colleagues and I are talking about as potentially of interest. As I mentioned, we're hoping to increase the frequency of study visits to monitor HPV acquisition among those who are initially negative. As I mentioned earlier, and we also heard brief insight in her introduction into some of the work that Chemtai is doing. There's so much happening right now with the application of AI to cervical cancer screening, and we may be able to integrate and explore some of these algorithms and tools into our protocol here. My understanding of the research to date suggests that thermal ablation is performing well among women living with HIV, but we will have an opportunity to follow the outcomes of those in our cohort who are treated with thermal ablation to confirm those promising findings. We are very realistic that new algorithms and tests can be accompanied by increased costs that will be a significant barrier to larger scale implementation. So we're hoping to embed data collection that can specifically inform cost effectiveness. So whatever screening algorithms we end up recommending as a result of this study can be accompanied by cost effectiveness evidence. I think that's the last slide. So thank you very much for hanging in here on the third presentation and offering your attention. And we look forward to any comments or questions now. And you're also welcome to follow up with myself and my colleagues listed here on the slide. Thank you.
Thank you so much, Dr. Thompson, for a fantastic presentation. We now have a few minutes for Q&A, and we will run over just a few moments. Of course, if you have to leave, we understand. I also wanted to point your attention to the fact that Dr. Omeka has answered a number of the questions in the answered box of the Q&A, and thank you, Dr. Omeka, for doing that. And so if I could ask the speakers to unmute themselves, and I will ask questions. I think my first question's for Dr. Omeka. Could you speak briefly? We had a number of questions about moving to HPV testing and moving from cryotherapy to thermal ablation. So if you could speak to PEPFAR's openness to adopt new technologies.
Right, thank you so much. Thank you, everyone. Let me start with HPV testing, which is primary prevention. Reading through the MER indicator reference guide, primary prevention is not the focus for PEPFAR. The focus for PEPFAR is secondary prevention, and that's screening and treatment. So, but I know for Tanzania, the government of Tanzania have programs also, other programs supporting HPV. So it mustn't be PEPFAR, it can be supported from other donors. Then on the thermal ablation, unfortunately for Kenya guideline, it's not there yet. It's, the guideline is a bit old, and I know very soon there will be an update, and I'm very optimistic that thermal ablation will be part of the new guideline because of its ease and because of it's less challenging for the logistics. So, but for now, what we have, the platform we have is cryo, and for the project is expected to leverage existing structure. So, introducing a new platform will be out of the scope of the project. So, what we're doing is to leverage on the current platform and scale service. But for sure, thermal ablation will be included in the revised guideline.
Thank you. There was also a question about recurrence of lesions in HIV positive women and what proportion of women might get recurrence. Perhaps Dr. Chemtai, you could speak to that?
Yeah, sure. So recurrence is a problem. It's an area of active research. Really up to 25, even 30% of women have recurrence. And this depends on several things, including immune suppression. But it's really critical. But in general, recurrence is high, which is why the cascade issue is very critical. HIV positive women will not be treated one time and don't follow them up forever, because you have to have her come back, and she's among the 25 or 30% that has recurrence. Then she needs to have further treatment, and often that will be a different kind of treatment. And some of these algorithms are still under investigation, but recurrence is quite high, and this is an area of active investigation.
Great, thank you. Dr. Thompson, a question about why vaccination would be considered for HIV positive women.
Yes, I didn't speak because we were running out of time. I didn't specifically address that, although I know I had it as a bullet on my last slide. There have been some studies, primarily in South Africa, that have looked at the use of HPV vaccination among women who are infected with, already infected with, well, that have already, initiated sexual activity. And I think the research there is a little bit inconclusive about whether or not it will have an effect. The studies that ULACNet will be looking at are looking much earlier. So looking at administering the vaccination to adolescents and looking at that. So there it would be more of a primary prevention intervention.
Great. I'd like to ask each one of the presenters if you could tell me and all the participants your top 2 areas of research. What do you think we need to know more of for prevention and treatment of HIV positive women? Starting with Dr. Chemtai.
Yeah, my 2 top areas of research, one is thermal ablation and its use amongst HIV positive women. Thermal ablation holds significant promise compared to cryotherapy. It's very new, and because HIV positive women are at significant risk, high recurrence, some of the work we're doing is looking at how safe this is and who is the right woman to use thermal ablation. And I'm very excited about the work on artificial intelligence and the potential for bringing very accurate screening on a phone that a nurse in a clinic in a rural area might just take a picture of the cervix and immediately get a result that's very accurate that can afford access to treatment. It's, within, hopefully in the next 5 to 10 years, this might be a possibility.
Thank you. Dr. Omeka, briefly, please.
Okay, yeah, for me, I think kind of finding a way to determine the kind of long-term outcome of all these women that are getting screening and are getting treatment. I would like to see for HIV positive women, the long-term outcome. Many of them are getting recurrence or anything. Then of course, I'm also interested in seeing if we can use mHealth services to improve the uptake of cervical cancer screening, where especially HIV positive women will be reminded through a mobile SMS text message or something, and see what difference it can make in service uptake.
Thank you. And Dr. Thompson?
Yes, thanks for that question. Obviously, ending on a research note, I'm a little bit biased because one of my leading priorities is having a better handle on which screening test or combination of tests can perform best among women living with HIV. But I really am also thinking ahead to scale and implementation. And so I think we can't lose sight of when we're often looking for quote unquote the perfect test. We also need to be studying very carefully what the service delivery environment is like and thinking about implementation science approaches to better retain women in the care cascade. And I want to echo the shout out to the use of mHealth strategies to engage women. And another niche area that I would be interested to explore with more time and more funding is applying a behavioral economics lens to how we can keep women and providers engaged in cervical cancer screening.
Great. Thank you so much. I realize we have a lot more questions, and what I'm going to suggest is that we will get answers to the questions that you've asked, and we'll put out a blog that answers your questions, because there's some really good questions. I see a lot of questions about Nigeria in particular, about the quality of programming, and unfortunately we're out of time, and I want to make sure that we get them answered. You can also send us questions at info at togetherforhealth.org, and we will make sure to get you answers to those questions. I would really like to sincerely thank our panelists for their insightful presentations and for the important work they're doing to save women's lives. Thank you for joining Together for Health, FHI 360, and PATH, and thank you to Petra Stankart for organizing this webinar. We wish you all the best during this very challenging time. We will be posting the presentations and the video very soon. Keep well and enjoy the rest of your day. Thank you.
Thank you, everyone.
Thank you, everybody. Bye.
Bye.
Thank you.
Stay well.